Hello, everyone. My name's Emma. I'm the LTV implementation lead for the LTV skills program, and I'm from the Pan Thames LTV program. And my colleague Mel is also with us, who is going to talk after me. So I predominantly deliver LTV education across the South Thames Paediatric Network, and we've been asked to join today to just discuss the acute LTV admission. So because this was an acute webinar, I thought I wanted to just recap what LTV is. And I'm really sorry if everybody's really happy with what LTV is, but LTV refers to the various types of respiratory support provided every day for a period of at least 3 months. Ventilation can be delivered either via a tracheostomy tube, which is invasive tracheostomy ventilation, or via a face or nasal mask, which we call non-invasive ventilation. The aim of LTV is to improve survival and quality of life in people with conditions that have led to respiratory failure. So, as I just said, we can deliver LTV in 2 different ways. We can deliver it non-invasively. Predominantly, we try and do a nasal mask where possible, but we do have children who are on full face or total face masks as well, or we can deliver it via a tracheostomy. The child could be ventilator dependent, which means they're ventilated 24 hours a day, or it could be that they're just nocturnally ventilated. So when you're looking after a child on LTV, it's essential that you actually know why they're ventilated and how long they're ventilated for when looking after them. So there's 2 modes that we deliver. So CPAP, which we've just had a really good introduction to. So CPAP is continuous positive airway pressure, and it's delivered through that continuous positive flow throughout the respiratory cycle. We can deliver it on all of our machines, and it could be a very simple CPAP machine, but if they're a baby, they're highly likely to be on quite a complex machine that's also capable of delivering life support, and that's just because of their size that they have to go onto one of those machines but they are just receiving CPAP. CPAP requires the child to be able to spontaneously breathe. And then we can also deliver bi-level ventilation or BiPAP, which I think is quite commonly referred to. So bi-level positive airway pressure. And with bi-level ventilation, there's 2 pressures of ventilation that's delivered. So there's an inspiratory pressure called the IPAP, which is delivered during inspiration, and the expiratory pressure, EPAP or PEEP, which is delivered during expiration. Most of our children will also have a backup rate set. Bi-level is an umbrella term, so there's lots of different versions of bi-level that the child could be on, and our ventilators can deliver. We can support a child with their own respiratory effort, so we support their own breathing and just make their breathing more efficient, or we can control and mandate their breathing. So it really depends why that child is ventilated to what type of bi-level support they are on. And we have 9+ ventilators within the South Thames Paediatric Network. And as with the machines, they all might call them something slightly different. So my advice to you is the manuals are really helpful at explaining them. But some examples of different bi-level modes include ST, pressure support, pressure control, SIMV. Lovely. So why are we here today talking to you on an acute invasive ventilation kind of webinar? Well, our LTV population is increasing, and right in the middle there you can see our most recent data. And so we have 410 patients just under 2 years ago that we recognised have LTV. 3/4 are non-invasively ventilated, with about 1/4 of the population ventilated. Our tertiary centres are all located in London. So our tertiary centres for LTV are King's College Hospital, St George's Hospital, Evelina London, Royal Brompton Hospital. And some of our patients may also be under north of the Thames, which is Royal London and Great Ormond Street. Our children are obviously located across the whole of the STPN, and if they require hospital care, their advice is to not go to the tertiary centre. Their advice is to go to their local hospital for safety and stability, which is why we deliver LTV education, because we know that our LTV patients do present locally, they do present to A&E. Some hospitals are able to admit, and they've set up policies in place which we can help you with to be able to safely admit patients into their wards. So we therefore kind of are developing a big education drive to support you for when the LTV patients do admit. So part of that includes, just before Christmas, we released our LTV e-learning. It's available on the LMS platforms for both South and North Thames. So I think everybody in this call probably is from the South Thames. So it is on the STPM website, and you can access it through that. And we'll put a link in the chat as well. And that's an introduction to LTV, and that's targeted at all healthcare professionals working within a hospital. And we've received fantastic feedback, and it's being used across the whole network. So we're really proud of it. So that's the first line of education. If LTV is new to you, or you haven't done LTV for a little while and you just want a refresher, this is the perfect place to get that information. We also host LTV study days across the region, and I pulled up a map with lots of red dots. So the red dots are where I've been, or we've been, should I say, to deliver LTV education since we started the program in 2022. We will happily come as much as you want us. We can come for full days, we can come for part of a study day, we can join virtually. Our education is free, and just able to support you and work in partnership with you to deliver the right LTV education that you need. And then the other thing is just to be aware of the LTV clinical guideline. We recognise that you might only meet an LTV patient once every 6 months, and there's a lot involved in LTV admission. So we created this LTV guideline. It's a complex document. It was meant to be 6 pages. It definitely is not 6 pages. And for those of you that have seen it, you will know it's not 6 pages. But the first core part of it is kind of core information, safety-based, information about dopes and the respiratory action plan, etc. And then the appendices are the things that we think that we got asked about. So how do I put oxygen on? How do I put a humidifier on? Troubleshooting guidance. How do I fit a mask? All of those things. How do I put a nebulizer through a circuit? All of those things are available to be able to give you that information very quickly. It's available electronically, and you can also download it and print it as well, whichever works best for you. I put a picture up of one of my favourite pages, which is the definitions. I think the definitions, there's so many definitions we have to remember, and this is all the definitions that hopefully will help you when you're looking after a child on LTV. So you've got the modes on the top left. On the bottom left, you've got the actual settings. So what does the IPAP, EPAP, backup rate mean? What do they mean? And then on the right, the really important thing when you're looking after a patient, the assessment. What can I learn from my ventilator about how my child is ventilating? So tidal volumes, minute ventilations, and leaks. So just to be aware of the guideline, where if you have a child admitted, is our recommendation. Other things pre-admission, hopefully this is a familiar document and you have seen it on your walls, but this is our LTV hub. It's a poster we update at least annually, and more so if we know there's new ventilators coming out. But it's a one-stop shop with everything you might need to help you look after a patient acutely. It's got ventilator specific guidance, it's got how to set circuits up, it's got access to the guideline and the e-learning that I discussed as well. So we update it regularly. We know there's a new ventilator coming, so we're already planning how to get resources for that and onto here. So my question for you is, do you know where your LTV hub is located in your trust? Where is it in your emergency department? Where is it in your children's ward? I ask this question on every study day, and everybody knows, which I think is just amazing that it's become a familiar document and poster in all the hospitals that we teach at. The other really important pre-admission kind of preparedness for a child to come in is that every child on LTV has a respiratory action plan or equivalent document. So this is a passport, could we call it that, about that child's LTV care, their prescription, their ventilator, their escalation process, their hospital plan. Everything you might need to know in regards to their LTV is in this document. Across the network, we don't have all of our hospitals using one document. So when we say respiratory action plan, we mean any document that the hospital provides. So just a couple of documents that we do have in our network. We have home care ventilation plans, respiratory action plans, and respiratory documents. So you just need to obtain this document when you're looking after them, and it really can be used to help inform and inform the care and decisions that you're making and support the escalation process that you have. They are shared widely by the LTV teams every time they're updated, and that includes the local paediatrician. So we've got some absolutely amazing good practice happening within our hospitals, where these documents are then stored in a certain place on everybody's electronic records, and the team know that they're there. So do you know in your trust where these documents are stored on your patient records? Do you have a process? And if you don't, it's a real recommendation to have it and make sure that everybody's aware of it. The parents and carers do also have a copy, so they should bring it in. They're taught to bring it in, but in that moment, it might not have come with them. And your tertiary centre will also have a copy of their plan, but they're really helpful and they guide and inform the care that you can provide. So, on admission, what do we have to do if we have a child on LTV? And I know this sounds really, really simple, but undertake a systematic full A to E assessment. Just because the child is on a ventilator, please don't just stop at B. The reason they've come in and the reason they're unwell may not have a respiratory cause. So do a full systematic assessment of our patient. Make sure the RAP is in your handheld notes, it's easily accessible, and it's being utilised and used as part of their care plan. Please inform the LTV team as soon as the child presents to hospital. As part of the parent's own escalation, they are already likely to have let the LTV team know that they're there, and they are there to support you in caring for the child when they present. And if needed, early escalation to transport and STRS services is advised. I'll go over this one quite quickly because Mel's going to do a quick case study. So it's really important to consider why our child is on their ventilator and how it is supporting them. If we could have as an example a child who has SMA presenting with bronchiolitis, they would not present as a typical broncholytic picture with increased work of breathing due to their disease process. So the respiratory action plan will be able to tell you how your child will present, what they will look for, and any action that you could take. So it's really important to know why they're ventilated and how long they're ventilated for. Utilise the child's own equipment. Most or many of our children have unwell settings now also programmed into them. So therefore, if they meet that criteria, you can escalate up, and it doesn't require unlocking the ventilator and changing settings. They're already pre-programmed, ready to go in that safe environment. And then consider humidity and secretion management. This respiratory action plan on the screen is really helpful. It's really clear, and it's got lots of information about secretions and further management. Does the child have a physio? Is physio already part of their care? Do parents do it? Can we call physio? Can we get them involved early? Circuits are really important. Our children are discharged with 2 circuits, one dry and one wet. The dry circuit is used for travel and transport. So if your child does come in with a respiratory illness and they are on their dry circuit in the ED, we need to get them into an environment as quickly as possible where they can be put onto their wet humidified circuit, because it really will aid their secretion management, as well as providing any nebulizers, etc. And I've just taken a quick snapshot of one of the one of the hospital admission plans that's in one of our sample plans, because I think it's really helpful, and it really guides you to what you can do from a medical perspective as well. And I will stop sharing, and I will let Mel take over and give you a quick case study.
So the case study I've looked at is one about secretions. As a physio that's joined the team recently as part of the education team, I'm very keen to bring an AHP slant to education that is given in the STPN and across Pan Thames. So I'm thinking of a case study of a 1-year-old. Can read all of this stuff. So we haven't got lots of time, so just going to neuromuscular, SMA2, NIV, 16/6. They've had increased work of breathing over the past 24 hours, and they've got increased physio input at home, reports of saturations where they've of 85 to 94, and they've just been admitted and they're on their dry circuit. So as you can imagine, I am going to ask for a bit of participation from you guys in the chat shortly, just to see what you guys would be thinking if this child presented to your A&E, your ED, and then onto the ward. So this is what a lot of you would be recording. So you would see on your Pews chart what kind of things you'd be recording, going through with those obs. So I'll just put that up on the screen for a second. So now kind of thinking about that kind of thing, if anybody could write in the chat, what would your actions be? So you've got this patient, this neuromuscular patient, what would your actions be? This is going to be really quick, so just a few responses would be great. Looking at that as a physio coming in to review this patient, respirates up a bit, head bobbing recession, saturations are a little bit lower and they have been reported to be lower. Oxygen, they're not on any. Well, that's really normal because it's a neuromuscular patient. Circulation, we're looking at heart rate's up a little bit, BP as well, cap refill's okay, temperature's up. So my immediate reaction is to think of, okay, is there anything I need to do immediately? It's great that people are starting to think we've got give oxygen paracetamol, needs to get onto wet circuit. Well done for seeing that. Unwell settings, as we've just said, they might have that. So brilliant. Respiratory action plan, yes, brilliant. Unfortunately, the physio plans aren't as neat and organized as the RAPs that they have for nurse and doctor settings, and we're hoping to review that and make a change in the future. Put on the wet circuit oxygen, cover for infection. Yep, we'll be thinking about that, what's going on there, review and response to this. So brilliant. So is there anything that needs to be done immediately? So where are we on our Pews chart? Using that, somebody said yesterday on a study day that I was in Brighton, it was alarm fatigue. So sometimes with the Pews charts, especially when these children are coming in, when they are registering as high, we just always are, oh, the pews are high and therefore we don't need to do anything. But actually it is really important to read what the escalation is and not kind of just kind of gloss over those points, because the pews are there for a reason. And then if needed for the nursing staff, the SBAR, and then of course the basic life support that we've been talking about as well today. So hopefully that's kind of given you an idea of what the observations are going to say. Some people have given some great ideas of what we can do. So what changes can be made? What questions can we ask? What about our airway clearance? Can we do suction? And I'll talk a little bit more in a second. Being a physio, I love to talk about secretions. What about auscultation? What's going on there? This patient's like doing okay, but they do have those coarse crackles, which is making me think more, okay, is there something down there that's causing some restriction to that airflow? What about our circuit and our mask, which people have already said about and Emma's touched on, so I won't go too much into it, but wet circuit, because we've been on our transport dry circuit, we're on a nasal mask. Do we have another mask that we could use, like a face mask? And as Emma mentioned, BiPAP settings, is there another program for the unwell settings already ready to go that we could flick them onto very easily? Paperwork, again, everyone's gotten that, highlighted that one, which is great. You've got your RAP. And then physios generally have a separate physio plan, a suction plan, a cough assist plan, or another device plan. So moving on to airway clearance, I'm not going to ask you all of these things. I'm just going to present them to you. And then if anybody's got more questions, or if anybody feels that their physios could do with linking up with me, please do share our details and I'd happily get in touch with them. Thinking about humidity, we've talked about that a little bit already. Nebulizers, what can we nebulize? Hypertonic saline, could we use bronchodilators and other nebulizers? What about positioning? Can we think about how we're positioning them? What about sputum sample? Has that been sent off? Somebody's already mentioned about cover for infection with IV antibiotics. Exactly that. Can we get a sputum sample? Can we get some more direction at what antibiotics are going to work for this patient, or if it's viral? What about secretion management medications? Are they already on something? Do we need to address that? Do we want to continue with it, or do we think that we should be lowering the dose? I'm just having a look at those things that they already come in on that works on a day-to-day basis that may not be working for you now if they have copious secretions. And they're thick and they're causing plugging. Manual techniques going on towards physios, physio support, as other people have mentioned throughout the whole of this webinar today, and how we can get some physio support. They can just sometimes be an extra pair of eyes that looks over this patient. It may not be that they can do manual techniques if it's a bronchiolitis baby, but thinking about how they can support that with positioning and advice on that acute management of that respiratory patient. These neuromuscular patients, physio is incredibly helpful. And what adjuncts have we got? I put MIE, which people might notice, rather than cough assist. Cough assist is a trademark term, so that's why we have to use MIE, which stands for manual insufflation exsufflation device, which, as you can tell, is a bit of a mouthful, so I call it MIE. You've got the vest, which is used with some children, which vibrates the chest, which helps with secretion management. That's used with a few patients, but due to the lack of evidence of it being useful, it's in research, we struggle to get it funded for, but some families find it very useful. And the PET mask, which gives some positive end expiratory pressure, which helps with those secretions. So just some ideas of that airway clearance. You're probably doing this every day, but how you can get your physio involved and how you can all work as a team. And there's always the wider team as well, wider investigations, got your doctor's reviews. What other investigations can we do? Chest x-rays, ultrasounds, bloods, blood gases. And as we've already said, STRS, local anaesthetic team, parents and carers support. The parents do physio with a lot of these patients 4 or 5 times a day, so get their support, get them in to help you. And also looking at the wider team, the tertiary centres, CNSs, for help, and then looking at those Pan Thames LTV guidelines that we've been talking about. Look at those posters where you might be able to support you with that ventilator that they're using as well. So just finally, as a review, this is our Pan Thames LTV education contact details. So if you want to find out more, feel free to scan. We've got a website, we've got email addresses there that link us into our whole team. So if you want to get in contact with us, please do. We'd love to hear from you and support you in any way we can with this cohort.